Hey, hello everyone. Welcome. We are so glad that you are here this evening for part one of our AUA Newsworthy Roundtable, Breaking News and Bladder Cancer Advancements. I'm super pleased and honored to introduce tonight's moderator, Dr. Ashish Kamat, and his conversationalists this evening, Dr. Laura Bukovina and Dr. Kristen Scarpata. Thank you all for taking time out of your busy holiday schedules to be here for this important discussion. With that, I will turn the mic over to you, Dr. Kamat, and thank you for getting us started.
Thanks, Jennifer. Thanks for the invitation, and thank you to all of you for joining us today. I'm joined here by two fantastic panelists. I'm Ashish Kamat. I'm professor of urologic oncology at MD Anderson Cancer Center, and I'll let my panelists introduce themselves. They don't need an introduction, but Kristen, if you want to introduce yourself, and then Laura.
Yes, hi, thanks. It's great to be here. I'm excited for our discussion. My name is Kristen Scarpato. I'm a urologic oncologist at Vanderbilt University Medical Center down in Nashville.
Thanks, Ashish. Thanks, Jennifer, so much for having me. My name is Laura Bukovina, and I'm an assistant professor of urologic oncology at Case Western Reserve. Very excited to be here and discuss everything in bladder cancer. I think there's a lot of new confusing information. I'm so glad AUA is having this discussion for everyone.
So, we thought we'd keep this whole thing very casual, informal in some ways, and then conversational. And if any of you have questions, or if you want to, just raise a point, or you disagree with something we say, feel free to put that in the chat. Our moderator behind the scenes will collate those and then send those to me, and I'll try to address them one by one. There's been a lot that's happened in the field of bladder cancer in the last year, and then definitely if you look at the last 2 or 3 years, it seems like since 2020, one bad thing happened, but after that, a whole bunch of good things in bladder cancer has occurred. There's lots of developments, and it's not just in one particular space of bladder cancer, right? Because for decades, it seemed like everything was happening in the advanced metastatic space and nothing was happening in the muscle invasive space, other than some technical refinements with the robot and things like that, and nothing was happening in the non-muscle invasive space. But there's been an explosion of really drugs, devices, therapies, knowledge in general. So I thought we'd kick this off by essentially starting out with the early phases of disease and going from there and progressing along the way. So Kristen, let me ask you first off, what are some of the advances when it comes to diagnosis that you feel have made an impact to the way you take care of patients with bladder cancer over the last 2 or 3 years?
Yeah, thanks. In terms of diagnosis, I think it's to kind of highlight what you just said. It's amazing all of the attention and resources that have been put into bladder cancer, which has kind of been an orphan disease state for so long. But I think there are important advances that have occurred in terms of endoscopy and bladder cancer biomarkers. I am an avid user of blue light and have been for the past, I don't know, about 9 years here at Vanderbilt. So in terms of diagnosis, that's probably what I'm relying on for most of my cystoscopies, who have certainly a history of high risk disease or have a positive cytology, but I would say also in terms of biomarkers, we're starting to use a little bit more CX bladder as well. It makes sense when things come into contact with the urothelium that you would see some sort of a signal in the urine that could be important and indicative of disease recurrence or the presence of disease. And I'm really kind of excited about some of the newer next-gen sequencing urine tests that are kind of coming down the pike, like Convergent, which can maybe indicate that someone has had a response to intravesical therapy or not, but can detect disease that has recurred before we can maybe see it with our own eyes. So I'd say those are two things I'm excited about and using.
Yeah, and I'm glad you brought that up because, when it comes to blue light, of course, since 2008, when it was approved, we've used it here more for resections, not so much in the clinic until the more recent approval. And of course, the only marker that really is in the guidelines per se is cytology, which should be standard of care, and of course the Eurovision test, which has been made its way into the guidelines more to monitor patients who are being treated with BCG. The other markers sort of come in and out of favor, and they haven't really gotten traction in clinical practice, partly because it's often the disease that you don't necessarily need to pick up that they pick up, which, aggressive disease that you would go after anyways with a biopsy. But I want to ask Laura, what's your take? Because, the newer generation of urologic oncologists coming in that are seeing this explosion of markers and diagnostic tools that we have. Interested in your take. What do you think are some of the tools that you look to when it comes to diagnosing a patient or monitoring a patient with bladder cancer?
Thank you for that. So I think there's a lot of new tools that I particularly started to use in my practice that certainly during training I have not seen others use. One is blue light cystoscopy, like Kristen pointed out. The other thing that I find using more and more in even non-muscle invasive bladder cancer is the use of MRI, particularly prior to TURBT or even post-TURBT prior to BCG therapy. Clinically, I think a lot of times not even if it does not change how you practice a non-muscle invasive disease, it does potentially offer information in terms of the therapy you provide and how quickly you potentially change therapy in the patients. So that's one thing that I personally am very aggressive in many of my patients who have papillary disease during cystoscopy and a concern for a large bulky tumor over 3 centimeters. They immediately get an MRI of the pelvis. Obviously, this is financially constrained for some of the patients, so that's always taken into consideration pending the insurance, but if possible, the MRI is one of the things. In terms of the urine biomarkers, or what we call, whether it's CX Bladder or EpiCheck or any of the new developing technology, I think urine cytology is the gold standard. However, over the next 5 years, we'll see that many of these companies will be used as adjunct to either surveillance for patients who have no evidence of disease, to decrease our surveillance cystoscopy times, or potentially for hematuria screening, particularly gross hematuria screening. So even though they're not essentially approved now, with the amount of data that we're getting on these urine biomarkers, or I would call them markers of residual disease or even new disease, there's compelling data to show that they're better than cytology. We just don't have necessarily the sensitivity or the positive predictive value that we need to be able to use those on a regular basis just yet, but that's always evolving.
Yeah, I mean, again, just to emphasize, those are still research tools, but the research is heading in the right direction. I think, in the next year or two, hopefully we'll have a lot more compelling data to be able to say that maybe these should actually be used in clinical practice. Let me push you a little bit on the MRI issue, because I know that my colleagues across the pond in the UK and Italy really use MRI at the drop of a hat. I mean, they just get MRI on everybody. And it sounds like you are a believer in the power of MRI. Share with us a little bit as to how you actually use it to change management of your patients. You say you get it in almost everybody that has a tumor that's more than 3 centimeters. Share with us a little bit, because I personally have not found their MRI to be as useful as my Italian colleagues or colleagues in the UK. It's good and it helps in certain situations, but I'm not that convinced. So convince us here, Laura. Tell us how you use it.
Yeah, it's challenging because it's a double-edged sword with MRI. So a case example would be a patient who comes in with gross hematuria and cystoscopy is a large bulky tumor. That patient, not just small papillary tumors, a large tumor, I would offer them to get an MRI prior to the TURBT. The reason is that if the patient is diagnosed with a T1 high grade, even on subsequent restaging with residual T1 high grade tumor, that patient is considered to be very high risk for recurrence and progression. In addition, if the MRI shows that there's concern for VIRAT score of 4 or 5, or sometimes they even are able to call out the stage of disease as T3 or T2 or T3, depending on the radiologist and their comfort level. There is a huge discrepancy between what my actual biopsy is to what the MRI is showing, and that really makes me more likely to offer more aggressive therapy or quicker therapy for patients to transition off BCG.
Kristen, have you been using MRI or other imaging modality to change or influence your practice?
I really haven't been using MRI routinely. There have been a handful of scenarios where I've had a patient who has a history of a bulky tumor and then has a positive cytology, and have done the standard blue light and evaluating the upper tract and evaluating the prostatic urethra, and I'm not finding anything. And we've used MRI in that situation. And on one occasion, I was able to identify a lesion that turned out to be actually a muscle invasive disease that was kind of like submucosal, but not something that I've been routinely using. No.
Yeah, and again, Laura, you may be having a unique set of excellent radiologists in MRI, because at our experience here, our abdominal folks that do MRIs all the time, I mean, they do a lot of MRIs, they themselves are not as convinced as when you talk to, for example, Jim Cato, or you talk to Nick James, because I know in the UK, for example, they will just do an office cystoscopy, a biopsy, and then use the MRI to take the patient directly to cystectomy or radiation therapy, which is the predominant modality of treatment. But we haven't been as fortunate, even looking at our own data, and we've done MRI for quite some time now, to be able to get to the comfort level that you have. So I'm curious to see if you have a series that you can expand on, and I look forward to an update from you in coming months. Now let's assume we've had this patient, we've diagnosed a tumor, and in today's day and age, everybody sort of takes for granted risk stratification, right? But if you drill down and you actually go into the nuances of what makes a patient a low risk tumor, low risk patient, a intermediate risk patient, high risk patient, there's a lot of nuances involved. So Kristen, could you share with our audience on a broad level how you categorize these patients in your mind and for next therapy steps?
Sure. Yeah. You have to consider the size of the tumor that you have encountered and the pathologic report in terms of depth of invasion and high grade versus low grade, presence of variant histology, which as our pathologists get better and better, we're perhaps seeing more and more lymphovascular invasion, CIS versus no CIS. I think honestly for low grade patients and for high grade patients, it's pretty clear what we're going to be doing, but the intermediate risk classification really can be challenging. And I have a hard time treating an intermediate risk patient who has low grade disease the same as an intermediate risk patient who has high risk disease. And I know that this is, high grade disease. Low grade and high grade are just different entities in my mind, and that's really where I really feel the decision making is quite nuanced in terms of what you might offer them for intravesical therapy and what duration you're going to utilize. But the factors that I kind of started with are really how I sit down and talk to patients and make a plan based on those factors. But certainly we know that high grade patients who are high grade are those who have any variant histology are in that high risk category, and they're the ones who I'm certainly going to treat much more aggressively. It's that intermediate risk group that can be a little trickier.
It's funny because when you actually talk to folks everywhere, that's what most people that take care of bladder cancer patients say, right? It's easy to pick out the aggressive tumors because there are clear signs that lymphovascular invasion, variant histology, histologic subtypes, all of that puts a patient in very high risk group. A first-time small low-grade tumor is clearly a low-risk tumor. And that intermediate risk bucket, just as you mentioned, most people separate out the low grades and the high grades when they're making treatment recommendations. But our AUA guidelines still have those tumors that are 3 centimeters or less and high grade in the intermediate risk category. But for example, the IBCG, SITC, we all recommend if a patient has a high grade tumor, put that in the high risk category, right? Because if I look at a tumor today and it looks 2.9 centimeters to me with the cystoscope, I'm going to call that patient intermediate risk. And if it's 3.1 centimeters to you, you're going to call that patient high risk. But how is that a valid distinction, right? So I agree with you. I sort of, if they're high grade patients, they go in the high risk category. If they're low grade patients, they go in the intermediate or the low risk category. Laura, your take on this? What are you following when it comes to risk categorizing patients?
Yeah, Ashish, I have to agree with you. I think any high grade is high risk. I mean, I think your data itself showed that even if you have TA high grade disease, the risk of metastatic disease and progression is almost equivalent to what you have when you have T1, slightly lower, but certainly not comparable to low grade with what is a 12% metastases rate. So high grade is high grade. It's the biology of disease, whether it's TA or whether it's 2.5 centimeters, it's still going to have the same biology as a high grade disease. So I completely agree, and compartmentalizing those patients into a high risk category. Now, I think our high risk category, we all know those players that are high risk and those patients that are very high risk. And I think that's a distinction that a lot of us, when we see the patients, know. The very high risk patients are the ones with large, multiple T1 high-grade resections, large T1 high-grade tumors, potentially variants, as Kristen said, CIS presence, lymphovascular, all of those are concerning for a very high risk. And I think within the AUA, we certainly don't have that distinction, which, the European guidelines do have it. So whenever I see a patient, I almost separate them, the high-risk category, into two separate categories. And I say you're high risk, but in my mind, I might think that it's very high risk at that point.
So tell me a little bit about how you counsel patients that fall in that very high risk category. Because over the years, I've become more and more aggressive with my counseling on patients. I take it as a personal loss if a patient with non-muscle invasive bladder cancer dies of their cancer, right? So I've gotten more and more aggressive when it comes to bladder cancer and less aggressive when it comes to prostate. But your take, Laura. So how do you counsel patients that are in that very high risk category as to cystectomy, intravesical therapy choices?
Yeah, first of all, I call it our gathering information stage. So whenever I get a patient with a tumor, I always tell them that we're going to get multiple scans and biopsies, and potentially we don't have the necessary data to say which therapy is best for them. Once, obviously I use MRI a lot in these patients. Once we get the biopsy results and the MRI results, and they are considered to be very high risk, I'm pretty upfront in telling them they're very high risk for progression and recurrence. I'm all for bladder preservation in these patients or participation in trials. However, if they're very high risk, I usually am upfront in telling those patients that there are an increase for potentially metastatic disease or progression of disease. So if you don't respond to BCG, or if you don't want BCG, because some patients do understand that there is a risk for metastases early on, and they do actually elect to have early on cystectomy. However, if they don't elect cystectomy, I'm aggressive in switching them to alternative therapy once they've done the induction BCG, the 5+2, and seeking out a trial for them, or then having an upfront conversation about proceeding to a cystectomy.
And Kristen, your take on this distinction?
Yeah, I agree. And your sentiment about having a patient die from bladder cancer when they started with you with non-muscle invasive bladder cancer is what you want to be kind of a never event. So I have become more and more aggressive in my counseling as well. And stressing the importance of timely or early cystectomy for certain patients who have bulky disease or may not be resectable or have recurrence and kind of a short interval time. I'm far more aggressive, and I think that they understand and value that, and if you spend the time with them, are willing to go forward with more aggressive treatment like timely or early cystectomy. But those are the patients that we worry about the most, for sure.
Yeah, I think it's very important for us to set expectations with patients, and no patient really walks to their door saying, I want my bladder taken out, right? Unless they're really having severe symptoms. And sometimes it's up to us to tell the patient, okay, fine, if we're going to try treatment X, that's great, but let me pencil you in at that 3-month time point for a cystectomy, just in case it doesn't work. Because then I don't want to lose time. And at least that gives them something to think about. And obviously, if they have a great response, you cancel the surgery, right? I mean, that's one way I do it, to kind of plant that seed in their mind. Because otherwise, it's very hard to revisit that with the patient every time you do an assessment and say, oh, it didn't work, now we need the bladder out. But today, we're fortunate that we have drugs that work in this BCG unresponsive paradigm, right? So we're seeing more and more patients that don't respond to BCG, or the tumor recurs after BCG, and then you have drug X, and we have some available and some that are coming down for approval. So with the plethora of agents that are available, I'm going to switch gears a little bit now. I'm just keeping an eye on the clock. And let's talk about BCG unresponsive disease. I think our audience that's listening knows that BCG unresponsive is a very different beast from BCG exposed or BCG naive patients. And in the BCG unresponsive space for years and years, the only real treatment option was radical cystectomy, and anything else was sort of considered substandard and not even to be discussed with the patient. But now we have options, right? So let me flip it back to you, Kristen. With what's available today, either approved or off-label or coming down into the approval pipeline, how has your thinking of BCG unresponsive disease evolved over the last, I guess, 2 years or 3 years?
Well, I'm much more optimistic, and I'm excited that we have more to offer to our patients beyond additional BCG or cystectomy. Or, when I first started out, we were still using Valstar from time to time in some of these patients. And so I think the future is bright, and I'm glad that there are additional therapies for patients. I am excited about kind of all of them, and the N803, so BCG with the IL-15 superagonist, like many of these newer studies and newer agents, really, I think, shows a lot of promise. And so I'm excited to see what the spring holds and what the FDA says about that. And then, the novel delivery systems. So we've been using the pretzel here for both muscle invasive and non-muscle invasive disease, kind of on and off trial. And I'm excited about that for our patients, minimizing the number of times they need to come in for catheterizations and, installation of intravesical therapies. And I think that there's so much more now that we can offer our patients. That's great. Like we just started actually using metaferrigine here for our BCG unresponsive patients, and so far we've had a really good experience with that. It's still quite early, but it's nice to be able to also, I would say, not have to go always to pembrolizumab for CIS patients who maybe our initial experience was not great for those patients. It can be really challenging and expensive, and I think it's a lot of goodness, a lot of good things coming.
Yeah, it's interesting you brought up valrubicin, right? Because for years that was the only thing approved, and if you actually look at it, even though when I say we, I mean, our group, the GeoASCR group led by Seth Lerner and the IBCG group, made this recommendation to the FDA to call it BCG unresponsive disease, meaning no more BCG. If you actually look at patients that are BCG unresponsive, they respond better to more BCG than they do to valrubicin. But that was the only drug approved at that point, and that's all we had, and it was dismal response rates. And then, of course, Pembro came about following the paradigm with about 20% at 12 months, and of course metaferrigine. And we have a lot of agents available. And Laura, you put out a really nice tutorial today, I think linked to this webinar on the different agents. Can you, I don't want to put you on the spot, and you may not have that in front of you, but at a high level, could you sort of summarize to our audience the overall response comparisons, with the caveat that we shouldn't be comparing across trials, but these are all single-arm studies, and where do these agents in your mind fall in the hierarchy of response rates?
Thank you, Ashish. I think there's so many now available, and it's fantastic for our patients. Only 2 are FDA approved. As Kristen said, pembrolizumab, which we know is about 19% at 12 months complete response, and it is systemic immunotherapy. Unlike nodoforagine, which is Ilstiridin, previously known as Ilstiridin, which is once every 4 months intravesical therapy. So unlike pembrolizumab, this offers patients to come in once every 3 to 4 months and get installation of, it's an adenovirus vector that allows sort of hijacking of bladder urothelium to produce more interferon. Now, it's interesting that it was just a monotherapy. I was curious that unlike N803, which was in combination with BCG, there was really not a BCG component. This was just a monotherapy of interferon. But their response rates are about 50% at, I think, 3 months, and I believe 24%, which is slightly higher than pembrolizumab, but still 24% complete response at 12 months. So that's, that's not great. It is approved. It is better than Pembro. The side effect profile is better than pembrolizumab. It's not a systemic therapy. There's no life-changing therapy like Pembro. However, it's easier to administer. It's only 3 to 4 times a year. It is FDA approved, so that's an option for our patients. Now, in the pipeline, the recent presentation of the BOND-003 trial at SCO, which looked at chromastogene, which is a type of Coxsackie virus that's also replication deficient unless you have a specific deficiency of an RB1 gene. So what essentially it does is it infiltrates the tumor cells that have a deficiency in specific type of an oncogene called RB1. Once it knows that it has this deficiency, which is only in tumor cells, it is able to lyse the cell, so kill the tumor cell and spill a whole lot of different antigens into the system. This is also considered to be a monotherapy. And in those results, the response was great. The response was 76% at 3 months and 64% at 6 months. There's no 12 months data yet. So however, their accrual is complete and it's considered to be a phase 3, and it's an expedited FDA review for that therapy. What I also find interesting is they also did this, Roger Lee did this in combination with pembrolizumab. So they combined the CRE with pembrolizumab, and their CR rates were much higher at 85% at any time, and 68%, which is the highest out of any therapy that we know to date at 12 months. However, we have to consider that, again, Pembro is a systemic immunotherapy with life-changing, life-altering effects. And even though they reported much less side effect than Pembro alone in the Keynote 057, those were still reportable about 4% grade 3 and higher adverse events. Now, back to QUILT, which, Kristen is probably with Sam Chang at Vanderbilt at 803. It's an IL-15 superagonist, and that was in combination with BCG. So we're thinking about BCG failure and giving more BCG in combination with IL-15, but it works, right? It works by heightening the response, really converting from innate to adaptive. And based on that data, they had 71% complete response, durable response with 45% at 12 months. So there's a lot of data out there. I think the CRE oncolytic therapy is very promising. I certainly think N803 still has a lot of data to show us. I think there's multiple things happening within the N803 trials. So I look forward to seeing more.
I just want to, sorry, she's just say again, what's a great tweetorial. Can we still call it a tweetorial, or is it an extorial?
Extorial.
No, I'm gonna call it Twitter, right? I mean, it's
Yes.
just like, how can you say exorial?
Yes. Well, Laura, you put out a really informative, educational tweet for everyone, going through, the different definitions of BCG, refractory, relapsing, unresponsive, and the available agents. And then you posted that interesting kind of survey result as well, which I was curious about. Actually, I hadn't seen that before, but y'all should check that out, her tweet.
Yeah, so again, since this is a AUA sort of a forum, I'm sure most of our audience are urologists at these scanning down, but I don't want to beat upon pembrolizumab too much, right? Because they were the first to follow the current paradigm. They went to the FDA, they saw the FDA. I was there, full disclosure at the panel, and they got approved. And it was clear that this was not going to be a home run. It was not a single drug for patients, but it was approved and allowed us to build on that backbone, as you said, CG plus Pembro, and then of course, TAR-200 plus their agent, PD-1 agent, in citrullimab, and of course the others. So I think Pembro has a role to play. We had a whole retreat here in Houston, the IBCG did last August or this August, to talk about how to sequence patients with the multiple agents that are approved. And one of the questions that just came up is, how would we treat a patient that has not responded to BCG, and then you tried pembrolizumab, and of course the tumors come back? I think the fact that we now have multiple agents available, approved, and we didn't talk about the standard of care right now, which is of course gemcitabine and docetaxel, right? So we have gemdosi, which has really good results in the real world. We have nadofaragene, which is now available in a few select centers. We of course have pembrolizumab, but we also have radical cystectomy. So let me flip this to you, because I don't want my bias to show in my question, but at what point, Kristen, would you tell the patient, okay, I've tried enough drugs, I really think your bladder needs to come out, versus, your recurrence is not so dangerous that it's making me nervous and we can try another round of an agent? How do you make that distinction?
Yeah, it's very patient specific. It really depends on a couple of things related to them and their disease course. You know, are they a candidate for radical cystectomy? Is an obvious kind of easy cop-out answer, but I'm going to keep going with all of these other therapies if they're not a reasonable cystectomy candidate. But if they've had a durable response with each of these different therapies and are not recurring, you know, in 6 months or 3 months, then I'm more likely to try and sequence these additional and newer agents. But I think we're pretty quick to try and pull the trigger on timely cystectomy here, if a patient we think would tolerate that, because of the risks that we talked about before of having them metastasize or die from their cancer. So I wouldn't say that there are many patients that I have had more than 2 or 3 different therapies before we're talking about cystectomy.
Yeah, and I think that's a great point that you raised. I mean, I did a little debate poll at the EAU this year, and it was amazing. Over in Europe, most experts felt that after one trial of a trial to save the bladder, the patient should go to cystectomy. Whereas on the US side, most people felt, at least in the poll results, were, let's keep trying things, right, till they become T2, and then you could do a cystectomy. And I think that's a message we need to re-emphasize. We don't want to wait till the patient becomes T2, because the survival changes. And Pat Hensley published a really nice update. If a patient goes from non-invasive bladder cancer to muscle-invasive bladder cancer, that patient has a worse prognosis than someone who presents with muscle-invasive bladder cancer. And again, there are several reasons for that, but we clearly don't want to wait till the patient becomes muscle-invasive. We want to treat the patient, and if you have to do a radical cystectomy, do that before that invasive component sets in. Now let's shift gears a little bit, because I don't want to spend an entirety of the rest of this on just the BCG unresponsive patients. But let's come to the earlier phases of disease, right? If you have a patient that receives a course of BCG, has a recurrence, falls in that BCG exposed category, and let's say it's a high-grade T1 disease, and it's not BCG unresponsive, so it's a year and you've had a recurrence, are you now more or less likely to push the patient to a cystectomy, or are you looking at the gemdosi data that's come out and some of these agents that we have available, less reluctant to recommend cystectomy? Laura, let me ask you, since you talked about the very high-risk category very early on.
It's patient to patient dependent. However, if we just sort of had to generalize, I think now, since we have options available, I would try alternative therapy such as gemdosi before going into cystectomy. However, that said, it would be with the understanding in patient counseling beforehand that we're going to try this, we're going to give it a go, but they have to understand the alternative, if they don't respond, is cystectomy.
And we were talking about BCG as though everybody has it. I mean, there's still a worldwide shortage, and we're fortunate that we have it. And I believe at your centers, you have it too. But just for the interest of those that might be listening in that don't have BCG, How are you recommending people address the issue of BCG shortage? So if a place has limited supply of BCG, what are you recommending they do?
So there's a couple of things you can do. You can triage patients who are considered to be high risk only to receive the induction plus maintenance. And then for the intermediate, you can stratify patients to gemcitabine only or gemcitabine docetaxel, depending if you have it. Some institutions and some private practices or practices around the country do not have access to gemcitabine docetaxel, including people in Europe. It's also not, it's not currently approved. The other thing is you can cut down your maintenance dose to 1/3. That will preserve the BCG supply. We've also actually had issues with BCG off and on over the last couple of years. So we have also done induction BCG followed by gemcitabine docetaxel maintenance. That's an alternative for patients. Otherwise, they would be not having any sort of maintenance at that point. I think you can sort of play around depending on how much BCG you have, find out how much access to gemcitabine docetaxel you have. And at the worst case scenario, mitomycin is an alternative to gemcitabine if it's available as well.
Kristen, any
Yeah, I agree with Laura and really want to just highlight, I think, the importance of prioritizing induction for high-risk patients. So that's really where I would put all the BCG resources. And then if there's available BCG for induction, then for maintenance, doing the reduced dose, and then for intermediate risk patients using gemcitabine or gemdosi if available.
Yeah, I think the key take-home messages there are that the duration of treatment is more important than the dose, and the induction is critical, right? And if you can keep those sort of principles in mind, it makes it easy to prioritize the BCG rather than try to figure out, on a case-by-case basis, who to give it to, who not to give it to. And that's of course assuming you have some. And if you have none, either refer them to a place that has a BCG or use gemcitabine docetaxel or something else that you might have available. So we talked about BCG unresponsive, and we talked about, the aggressive disease. Let's switch gears completely now to the earlier phases of disease, or the less aggressive disease. In prostate cancer, we've sort of accepted now active surveillance for patients. Kidney cancer, small masses, we do active surveillance. For the true low-grade patient that has this small tumor in the bladder, and let's assume the patient, for ease of discussion, is older and not enthusiastic in going to get repeated anesthesia. What's your sense nowadays, Kristen? Let me ask you, on monitoring these patients and doing active surveillance for that low-grade tumor?
Yeah, I'm comfortable with that for patients who have a known diagnosis of low-grade disease, a small, less than 1 centimeter isolated recurrence, monitoring them. And, if I had if I was able to do an office fulguration of that, I certainly would do that. But, it's hard to amass a clinical trial of patients who fit into this to give us kind of level 1 evidence. But I think there is reasonable available evidence that active surveillance for small, known low-grade bladder cancers is appropriate for some patients. So you've got to be pretty select about it, but negative cytology, known low-grade.
Yeah, no, you absolutely have to be selective, and the Italians have done a great job of sort of having the most prospective data. And then when Roberta Conteri was a resident over there, came and spent some time here, we looked at the IBCG criteria, and you can actually figure out which patients will do well with active surveillance based on a few things such as size, as you mentioned, absence of high-grade cytology, no gross hematuria. That's a critical factor that panned out. And of course, the number of tumors was 5. So if you have 5 or less tumors and none of them are more than 1 centimeter, these patients can go on active surveillance for years sometimes before anything changes. And I think it's a paradigm shift that we have to sort of understand and then follow, because we don't want to be running to the OR every time a patient has a small recurrence and putting them through anesthesia, all the mental issues that go with it, the quality of life, taking away time from work, etc. we were also now getting more and more treatments that are coming in that are ablative, right? So you've seen the Urogel and the mitomycin formulation, and of course, hemostaphid's data with intravesical mitomycin without gel formulation. Laura, what's your take on ablative therapy? Do you think that's something that's here to stay for all comers? Is it a more selective group of patients you think will use it in?
So this is, so the recent trial that was presented for UGN-102, which is was presented by Sandeep Prasad at SUO, talked about the chemoablation potential. Now, the problem with chemoablation, if we think about it, BCG is not tumoricidal by any means by itself. So in those intermediate risk patients, putting a BCG is not going to be tumoricidal. Mitomycin itself in an aqueous solution, so just if you put it into water or D5, it's also going to, as soon as the patient urinates, it's going to be out of their system. So the contact time between the actual chemotherapy and the tumor is short, in an hour, in order for it to do the activity that it's supposed to do. If your aim is to kill floating tumor cells, potentially there's a higher contact. However, if your aim is to kill potential chemoablation of the actual tumors that are in the urothelium, it's very difficult for anything that's water-based to be able to do that. And UGN-102 is essentially based on that principle, where it's more viscous, it's sort of able to stay in the bladder. It's a gel, mitomycin gel, that's instilled, and it lasts for 5 to 6 sort of urinations throughout the system. This allows that chemotherapy drug, the mitomycin, to be able to be ablative to the small papillary tumors. And in that data that they presented, they showed over multiple months, or less than 6 months, 80% of those patients were able to get what we consider to be a complete response. So no evidence of those low-grade papillary tumor recurrences. So that means we're able to save 80% of patients from coming back to repeat TURs if they have a recurrent low-grade papillary disease. And the remainder 20% of patients, those patients were able to get TUR. Now, the question is always on our mind, how many of those patients actually progressed? So if we have these recurrences, 5, 6, 7, 8 recurrences, how many of those patients actually progressed to high-grade disease? Because that's always, we're thinking about that as urologists. And only about 2% in their cohort progressed to higher grade disease, which is low, much lower than we would expect, and certainly very much agreeable with the data that they showed. So that's one of the therapies that I think is going to make a huge change in how we treat these low-grade recurrences in our patients on a daily basis.
Yeah, and again, that's a well-done study in a select group of patients, and just a intermediate risk, low-grade patients, right? Because otherwise you don't want to risk the high-grade patient getting treated. You mentioned about aqueous solution. The Danish group and the UK group have actually done it with aqueous solution and had quite similar results. So the Calibre study just used intravesical mitomycin, and the Dablaka study, of course, by Jorgen Jørgensen, used gemcitabine, and there were more frequent administrations to get over this issue. But I think one of the things that we all want to see is how does the Urogen compound compare to available mitomycin, available gemcitabine, and not just TURBT, because again, exciting results, and I think it's going to change how we manage some patients, but I don't think it's going to be for all comers. But I'm interested to see what you have to say, Kristen, about the ablative therapies.
I think there's real potential, and I'm excited about it. And I think from the patient experience side, which Laura kind of touched upon, there are certainly benefits. And there was a companion paper published in the Journal of Urology looking at the patient experience with UGN-102 that was very favorable in terms of their ability to tolerate it and their outlook. And patient-centered outcomes are such an important part of bladder cancer efforts these days, importantly. So I'm optimistic that we'll get to a good place with it. I want to see a little bit more data. What was presented at SUO is really very promising. And I don't know all of the details, but I believe that there's an erdafitinib pretzel that is being developed to also kind of work as an ablative technology for certain select patient populations as well. So I think that it's on our minds as something that is potentially really beneficial for our patients, and again offers kind of a novel way to manage our urothelial cancer patients. So I think I want to see more.
Yeah, no, I mean, stay tuned, of course, right? Because the TAR-200 is the gemcitabine pretzel, and then the TAR-210 is the ERDA pretzel. And there was data presented at ESMO. Believe it or not, I mean, ESMO is like ASCO, and they had data. They gave up a podium a slot for non-muscle invasive bladder cancer using this because in the small number of patients again, but the targeted therapy with intravesical ERDA had really great results. You know, you could actually ablate a whole bunch of these tumors, et cetera. So I think in the selected patient, I use it even today, right? So if I have a patient that has, say, 20, 30 tumors in the bladder, rather than take that patient to the OR up front, I'll do chemotherapy, I'll ablate the tumors. A lot of these tumors melt, and when I go to the OR, I'm left with maybe 4 or 5 large tumors that I can easily address. And that's based on some of the older data from Europe where they did that with the marker lesions. And again, even with some other patients, I will use aqueous solution even now, but of course, if UGN is available, I would switch to that. So I'm really looking forward to more results from there. You brought up, patient outcomes, and I think no therapy in the advanced space has had such an impact on patient outcomes as EV Pembro, right? Because for all these years, cisplatin-based therapy was standard of care. We were able to extend survival. And then when Tom Powles presented the data at ESMO with EV Pembro in the first-line metastatic setting, survival, median duration going up to 30 months. I mean, that was met with standing ovation. Just want to ask you guys, I know we don't treat patients ourselves, but at your centers, have you guys seen a switch to EV Pembro already? Is that coming down? What are you talking to your patients about if they, unfortunately show up in your clinic with metastatic disease as to your recommendations? Laura?
Yes, we have certainly seen a lot of, we actually have been using EV Pembro beforehand, even before ESMO. However, we've certainly seen an uptick in the amount of patients on EV Pembro. Sometimes these patients, either they present to oncology clinic and then subsequently as already metastatic, and then they're sent back to our clinic for repeat TURs because of symptom control or clearance, or even biopsies to confirm response. However, typically when we do see these patients and talk about therapy, I try not to step on any toes. Certainly, I don't know the data as well as they do. However, I do give them hope, right? Because ultimately patients need hope. And this is the first therapy that we have in many, many years that offers hope. My question, and this is something that I always think about, is we're going to start seeing patients who have remarkable response to EV Pembro, aside from the bladder, which I already had a couple. What do we do with those bladders? And that's something that I don't quite know the answer to. And I think collectively as a community, we're going to have to decide, what do we do in those patients where the only site of disease is the bladder?
Kristen, your take?
Yeah, I agree with Laura. And we definitely have to provide hope to our patients, and we're now able to with the rapid development in both the non-muscle invasive state as well as the muscle invasive and advanced disease. And I have seen us start to transition what we're able to offer our patients here at Vanderbilt as well. And it's really exciting.
Yeah, no, the question of what we do with the bladder comes up often, right? Because we've, even before EV Pembro, there are patients that get durable responses to their metastatic lesions, and then the only site of recurrence or persistent disease is the bladder. And clearly, if it affects quality of life, I mean, then the answer is relatively easy because the patient's having continued hematuria, pain, then talking about cystectomy is easier. But in a patient who's otherwise completely asymptomatic and just has tumor in the bladder, but just had metastatic disease, how do we time cystectomy? I mean, that's something that, again, we still offer patients, but the caveat of discussion of, well, now we have other treatments with more durable responses. Do we need to be addressing the primary tumor as aggressively, or can we use trimodal therapy with radiation or repeated TURs? I think that's evolving over time, right? And then that's something that's really something that we as a community have to put a lot of thought into, because we're going to see a lot more of these patients with metastatic disease coming back to us for management of their primary tumor in the bladder itself. Have you guys started using trimodal therapy to a larger extent because of this shift in patient responses at your center, Kristen?
Yes, we have. I think we still do, preferentially for many patients, treat with radical cystectomy, but the data look really good for trimodal therapy. And when patients are offered that, and I think urologists are much more comfortable talking about it now, they find it very compelling to keep their bladders. And when the outcomes are on par with what we see with what has historically been the gold standard, it's something that patients want more. And so, of course, I think we have to offer it to them. But we have an excellent relationship with our radiation oncologists here and a robust tumor board. And I think the collaboration is great, not only for us, but great for our patients. And offering trimodal therapy is something that I personally feel more comfortable doing now. And I think we as a center have been seeing more of it.
Laura, what your take?
Yeah, we certainly have a similar relationship in terms of TMT. However, we also offer the Janssen pretzel for muscle-invasive bladder cancer. So that's an alternative therapy for our patients who want to have bladder preservation in terms of muscle-invasive disease. And then we did have a relationship in terms of my previous relationship to the RETAIN trial. So many of those patients, even though not our TMT, with the RETAIN 1 and RETAIN 2, which was part of either chemotherapy alone, and then observation or surveillance if you have complete response, clinical complete response, or now in combination with immunotherapy without the radiation component. So bladder preservation in all different forms has been prevalent in our institution, and I highly support any patient who wishes to explore those options.
But just to clarify, I mean, all of those are still in some ways should be done on a protocol or with close observation, because it's not really standard of care right now.
Correct.
And I agree with both of you, and I would offer that to selected patients as well. But I think it just our clinical staging of patients still, despite the VRATs, despite MRI, TUR, urinary ctDNA, et cetera, it's still not to a point where we can guarantee, there's no guarantees, of course, but we still can't have a high level of confidence that, yes, this bladder is something that's not going to threaten the patient's life with a recurrence that's not curable at that point. So far this evening, the two of you have agreed on everything. I mean, in the last 5 minutes that I have, can I find something that the two of you disagree on? Laura, you want to throw something out there to Kristen and challenge her?
I mean, I think we have different opinion about MRI utility. That was the first question. We sort of have difference in how we use it. Let's see.
I was half kidding. I didn't mean to put you guys on the spot.
How about utilization?
MRI was going to be my answer too.
Exactly. How about utilization of single cell, about ctDNA as part of your workup in terms of using it as part of your guideline to counsel patients in cystectomy or potential therapy? Is that something you use at an institution?
I find it useful. I do find it useful. Kristen, are you using it in patients to sort of select who you would offer adjuvant therapy after radical cystectomy?
I'm not routinely using it now.
So let me ask you
there.
Based on Checkmate data, are you offering adjuvant therapy to patients with Nivo after radical cystectomy if they have these adverse pathologic features?
Yes, so we are, and again, it's back and forth with our medical oncologists pretty closely, but for select patients who have those adverse features and who could tolerate additional therapy after cystectomy, then absolutely, yeah.
Yeah, I'm using ctDNA on those patients because, until we actually have survival data, because it is not a non-toxic treatment, right? Nivo, it's not benign. And we don't have survival data out, and one study was negative. So that's where I'm sort of like fine-tuning it, and I'm using the informed ctDNA test, the one that Natera has, rather than the uninformed. And if they don't have residual disease that's picked up on ctDNA testing, we're less likely to offer them adjuvant Nivo than if they have it, clearly, because then you can offer that at them. So we're sort of tweaking that a little bit. I think we're close to closing, so I'm going to thank both of you for taking the time and spending it with our audience today. I want to thank everybody that's sitting and listening in. And of course, I want to thank the entire AUA News team for giving us this opportunity to share with you all everything, to do with bladder cancer. We could really have talked for another hour, but I think we're constrained and we're going to give back everybody's evening to you. So thank you again, everyone, and stay safe and happy holidays.
Thank you, everyone.
Thank you. Appreciate it.
Happy holidays.